Antibody-mediated nerve damage in CIDP involves autoantibodies targeting nerve structures like neurofascin, disrupting myelin integrity and impairing nerve conduction. This contributes to the chronic symptoms and treatment challenges of the disease. Chronic inflammatory demyelinating polyneuropathy, CIDP, is a rare autoimmune disorder characterized by progressive weakness and sensory dysfunction due to damage to the peripheral nerves. A key mechanism underlying this condition is antibody-mediated nerve damage, where the immune system mistakenly targets components of the nerve structure, particularly those involved in maintaining the integrity of the myelin sheath. In CIDP, the immune system produces autoantibodies that attack specific proteins located at the nodes and paranodes of Ranvier critical regions for nerve signal transmission. Among these proteins, neurofascin 155, NF155, contactin-1, CNTN1, and contactin-associated protein 1, Caspr1, are common targets. These proteins are essential for the formation and maintenance of the junctions between axons and Schwann cells, which facilitate saltatory conduction. When autoantibodies, especially of the IgG4 subclass, bind to these proteins, they disrupt these junctions without triggering inflammation, leading to detachment of Schwann cell loops and impaired nerve conduction. This form of damage is distinct from typical inflammatory neuropathies. In NF155 positive CIDP, for example, nerve biopsies often show demyelination without macrophage infiltration, indicating a non-inflammatory mechanism. The IgG4 antibodies involved do not activate complement or recruit immune cells, but instead interfere with protein-protein interactions necessary for nerve function. Clinically, patients with antibody-positive CIDP often present with more severe symptoms and respond poorly to standard treatments like intravenous immunoglobulin, IVIG. These cases may also show signs of central nervous system involvement, such as optic nerve or cerebral white matter lesions, leading to a classification known as combined central and peripheral demyelination, CCPD. Elevated cerebrospinal fluid, CSF protein levels, and hypertrophy of spinal and cranial nerves are common findings in these patients. Diagnosis of antibody-mediated CIDP involves serological testing for specific autoantibodies, alongside nerve conduction studies and imaging. Identifying these antibodies not only confirms the diagnosis but also guides treatment decisions. For instance, patients with IgG4-mediated CIDP may benefit more from therapies targeting B cells or plasma exchange rather than IVIG alone. Understanding the role of autoantibodies in CIDP has led to a reclassification of these cases as autoimmune nodopathies, emphasizing the unique pathophysiology and therapeutic needs. Ongoing research aims to refine diagnostic criteria and develop targeted treatments that address the specific immune mechanisms involved. In summary, antibody-mediated nerve damage in CIDP represents a distinct and complex subset of the disease. It involves autoantibodies disrupting critical nerve structures, leading to demyelination and impaired nerve function. Recognizing and addressing this mechanism is essential for improving outcomes in affected patients. If you enjoyed this video and would like to see more, please like and subscribe to this channel.